Today, in vitro fertilization or IVF is practically a household word. But not so long ago, it was a mysterious procedure for infertility that produced what were then known as test-tube babies. Louise Brown, born in England in 1978, was one of the first such babies to be conceived outside his mother's womb. To know more on IVF, we have with us today our expert, Dr. Sumana Manohar, Senior Consultant, Obstetrics and Gynecology, Reproductive Medicine, Endoscopic Surgery, and High Risk Obstetrics at Apollo Cradle, Shafi Mohammed Road, Chennai. Good evening, Doctor.
Good evening, Deepa.
What is IVF treatment, Doctor?
Yeah, basically, as you said, IVF treatment means in vitro fertilization, or the pregnancy, actually the embryo develops outside the uterus, and the embryo is replaced inside the uterus. When do we actually do in vitro fertilization? For patients who are seeking fertility treatments, or when there is a problem with the male factor, in the sense the count is less, the motility is less, or if there is any problem like a polycystic ovarian syndrome where they do not conceive on simple measures like ovulation induction or IUI, then we have to go for in vitro fertilization. Or if the tubes are blocked, then there is an indication for in vitro fertilization. The answer to all the infertility problems is not IVF. I would request my viewers to understand the fact that IVF is not the final thing which we have to go for, or the IVF is not the one. We should not take that as a first step. We should gradually do the simple measures and then go for the little advanced measures like in vitro intrauterine insemination, and then go for in vitro fertilization.
How safe is it to do or perform an IVF, Doctor?
It's very safe in a trained hands, especially the in vitro fertilization has to be done by people or doctors who have trained well in this, and because it becomes unsafe if you give a lot of drugs. The dosage of drugs are higher depending upon the age of the patient, depending upon the indication. You have to titrate the drug dosage. So if you give overdosage of the drugs, they can land up having hyperstimulation, they can land up having multiple pregnancies, and all these things can happen. So we have to fine tune the treatment protocol. We have to sit down with the couple, shed out the treatment protocol, and then start the treatment. Then it becomes safer.
What exactly happens during an IVF treatment, Doctor?
Yeah. So what happens is, say, for example, your doctors have been selected, the couple, for in vitro fertilization. Initially, we have to run through few investigations for the woman and the man. So the woman, normally we'll have to do a normal blood counts and make sure that she doesn't have diabetes, hypertension, her general health is good enough to go on for in vitro fertilization. Whether she had a pap smear to make sure that the cervical pathology is not there, and also do few investigations like how the hormonal profile is, how her ovarian reserve is, and how her uterus is, and how her ovaries are. There's no other pathology. And then at the man also, we have to do all the serology tests, in the sense HIV, hepatitis, VDRL, HCV, all that has to be done in the couple. And then we have to carry forward. If both are suitable and we have decided to go for it, then we have to bring the patients in. As a couple, we have to see them in the fertility clinics. We should never see them alone. And the husband has to come along with the women for the fertility treatment. So once she comes in, we also have to test her varicella and rubella immunity status, because they have to be immune to these diseases before they go ahead with the pregnancy. For the matter of fact, for any pregnant woman has to undergo these investigations before they conceive, which is called the preconceptional counseling. Like any other woman, even the IVF patients also have to undergo this. So once that is done, on the first or the second day of the period, there are different protocols which we use. It can be antagonist protocol or agonist protocol. Normally, at the moment, we are using more of antagonist protocol, where they come in on the first or the second day of the period, and we give them the injections, which are gonadotrophin injections, which will recruit the follicles. And once the follicular development is there, under anesthesia, we collect the eggs, and by a transvaginal method, aspiration, we collect the eggs, and that will be combined with the husband's sperms, like an ICSI procedure, intracytoplasmic sperm injection, we call it, under very micromanipulative techniques. The sperm is injected into the egg, and then once the embryo is developed, then depending upon the indication, we'll either do the embryo transfer on the day 3 or the day 5. Mostly we go for day 5 transfers, and we do not, which is called blastocyst transfer, where we know that the embryo has survived 5 days and to the blastocyst level, and also the implantation rates are much higher in these patients. So much higher with the blastocyst transfer. So because of this, we'll wait for day 5 and see how many embryos got developed into blastocyst stage, and we have to make sure that the embryos, not more than 2 embryos should be replaced, or a single embryo transfer is the method of treatment nowadays, because the risk of multiple pregnancies are higher with the 3 or 4 embryos, and that should not be the case, and we should resist that happening. We have to replace only 1 or 2. The maximum embryos has to be replaced on day 5, because the success rates, as I said, the success rates are much higher on day 5. And once, for example, if the patient is not suitable, say for example the patient had too much of hyperstimulation, or there is some fluid in the endometrial cavity, or we are not able to replace in that cycle, we normally do the freeze them, and then do the frozen embryo transfers at a later point of time, a month or couple of months later. But what we do is we'll prime the endometrium with the estrogen and the progesterone hormones. We develop the endometrial thickness, and then once they reach good endometrial thickness, we replace the embryos.
What is the difference between IUI and IVF, doctor?
Yeah. See, IUI is intrauterine insemination, IVF is in vitro fertilization. IUI is the primary modality of assisted reproductive technique, where we just have to, in these patients, say for example, the male factor, for example, they are not conceiving with a mild male factor, in the sense the counts are around 10 to 15 millions, or around 10 million sperms, and the motility is not that great, but that's not too bad. Those are the patients we can go for intrauterine insemination. And also patients we have tried with the ovulation induction, in the sense that we tried with the medications and we tried to see whether they conceive naturally by having natural relationship, and they did not conceive, then we go for intrauterine insemination. So basically what it is we stimulate in the sense the same way as in vitro fertilization. We give gonadotropin injections from day 3 to day 7 or day 9, day 11 of the cycle. Once the follicle is around 18 to 20 millimeters, we give a trigger called HCG trigger, human chorionic gonadotropin trigger, where that will initiate the maturation and the release of the egg. And then we'll do the intrauterine insemination by preparing the sperm and injecting inside the uterus exactly 40 to 44 hours later. After the trigger, we'll inject the sperm. That is called intrauterine insemination. As I explained to you before, IVF is another different process.
What is the right age for a couple or a woman to undergo IVF?
See, there should be at least minimum. There's no limit, the lower limit for this. But then again, the patient should be tried enough with other modalities of treatment, as I said, in the ovulation induction, with the timed relationship, and also with the intrauterine insemination. At least minimum of 3 cycles with a good center, where there's a good follicle development was there and good sperm preparation was there. In spite of that, she did not get conceived. Then we have to go for in vitro fertilization. The upper limit is only 45. We should not be doing the ICMR guidelines that suggested in 2017 that we should not go beyond 45 years of age for the women, and for the men, it should not be more than 50.
And how long is the process of IVF, doctor?
IVF, in the sense, if it's an antagonist protocol, it about 15 to 20 days, but then again, you have to take time off and read about it, spend more time with the doctors and the counselors, and get the right, you have to get into the right modalities of treatment, and also you have to know quite well about the IVF program as such. So basically, it starts off with injections, and then, as I said, it will be minimum of 15 to 20 days process. If you're from outstation, then probably you have to stay for a month till we get a pregnancy test positive.
Speaking of time duration, we've got a number of questions asking, why is my first time IVF process not successful? Why did I have to go for a second or a third cycle?
my message to the viewers is it's not 100% success. I mean, if it is really 100% success, we are next to gods. But basically, it's only 40 to 50% success. Even the IVF centers will say about 70%, 80%. It's not true. The maximum you can get is around 45 to 50% maximum of success we can get with the IVF cycle, especially with the in vitro fertilization and intracytoplasmic sperm injection. The success is around that much only. So it's not beyond that. You have to know that 50% success means 50% is negative. So you have to understand the fact that it's not every time you have it, it is negative. But then again, is positive. Then again, you have to sit down with your doctor and find out why exactly you went wrong in the first place. Whether your age is a problem, whether the male factor is a problem, the sperms are not good, or you are very old, like more than 40 or 45, more than 40 and below 45, or your egg quality is not good because you had a prior problem like endometriosis or a polycystic ovarian syndrome, where the egg quality may not be that good, and maybe the fertilization did not happen properly, or the implantation did not happen. What exactly is the problem? We have to troubleshoot the problem and then find out why exactly is the problem and rectify that problem with the next cycle.
When should patients approach an IVF specialist in the first place, doctor? And what should one know before going in for an IVF procedure?
Yeah. See, if you have been trying for, so you're married for 1 year and more, and then you've decided to have a pregnancy, then as I said, preconceptional counseling on the investigation should be done, and you try naturally. So you also have to know that it's not that, say, for example, you are working somewhere and your husband is working somewhere else and you're having relationship once in a month, and I'm keeping the ovulation kit, doctor, and I'm having relationship that time, doctor, but it's not happening. That doesn't happen. So you have to have regular relationship between day 8 to 20, alternate days, and more so around the ovulation time, so the success is much better. So you have to try that at least for minimum of 1 year if you're younger. Say you have approached 35 and it was a late marriage and you tried and it did not happen after 6 months, you can see the doctor. You can see the general gynecologist to start off with and see whether your problem can be rectified by simple measures like giving you little ovulation induction and asking you to have a relationship at a specific time, or measures like intrauterine insemination, and see whether that works. If it doesn't work, then you have to seek a infertility in vitro fertilization doctor, where you get a better approach. And also the in vitro fertilization should be referred by the general gynecologist to the specialist center.
Hello, doctor. I'm 27 years old. My AMH level is very low. What can I do to improve the egg quality? My doctor suggests us to go for IVF with donor's eggs, but I'm just not ready for it yet.
Yeah. See, you're very young, you're only 27, but your ovarian reserve is poor. So most likely that, there is a family history of premature ovarian failure where the ovaries fail little early than the normal, or there was a previous history of any surgeries like for endometriosis or fibroids that can decrease your ovarian reserve, and your lifestyle itself like smoking, alcohol, and late nights, and also having all the what do you call all the computer guys working in the software guys working late in the nights and not keeping their schedule properly, and eating habits properly, and sleeping habits properly. All this can affect your fertility. So it's fertility reserve. It's ovarian reserve which is represented there as an AMH, and it is on the lower side. So does anything improve? Maybe your lifestyle modifications can improve the ovarian reserve to a certain extent, but then again, it's very difficult once the ovarian reserve comes down to improve it. There are a lot of medications like DHEAs and all that which are being used, which are proven not so successful.
What are the benefits of IVF treatment, doctor?
When there is no benefit as such, always spontaneous pregnancy is much better than an IVF treatment, of course. If you're not able to conceive naturally, then IVF is naturally, and also by other modalities, as I said, and then go for in vitro fertilization. But the benefits as such, I wouldn't say it's more beneficial than a spontaneous pregnancy. But then if you have a patient who had a recurrent miscarriages, or you had who had problems like a previous babies had abnormalities, we can do something called pre-genetic diagnosis or pre-genetic screening and then replace the good embryos. So that is an indication that would say it's beneficial by undergoing IVF treatment.
Doctor, in your long stint as an obstetric and gynecologist and a specialist at high risk pregnancies as well as an IVF specialist, what are the success stories that you've seen? Something that you can share with us today?
Yeah, as soon as I came back from England, I had a patient. First patient was in ICU as a high risk obstetrician, who had a patient who had a lupus nephritis, and she had severe preeclampsia, and she had fits as well, and the baby was around 27, 28 weeks pregnancy with a severe IUGR baby. And then the critical care obstetrics in Apollo is very well spoken about, and it is, I would, it's in par with any other things in any other critical care in West. So actually, that patient, we really had to, I did a cesarean section because of preeclampsia, but post-operatively she had heavy bleeding, and also she had a lot of problems, like she had to undergo dialysis and she had to undergo a lot of other things, and she was ventilated for a long time, but the patient and baby came out successfully well, and the baby was named after my name, and the baby's name is Suman. So and she still comes every birthday and sees me, and that's extremely wonderful thing which can happen to a doctor. And other few things like factor 5, factor 8 deficiency patients, and who really bled, and patients who had acute fatty livers, liver pathologies, severely jaundiced patients, all these patients who came to Apollo, who needed critical care in obstetrics, they all went home successfully. So there are quite a few of them to mention.
Thank you, doctor. Hello, doctor. What is the cost of IVF with another sperm donor? If the male partner is having a 0 sperm count, what is the process and what is the success rate of the IVF?
See, if the male partner has got azoospermia, that is called 0 sperms, it doesn't mean it's the end of the story. It can be obstructive or can be primary testicular failure. So if it is an obstructive, we can actually do something called TSE, where testicular biopsy can be done. We can still retrieve the sperms by epididymal sperm aspiration and also by testicular biopsy, and that can be injected inside into the egg, ICSI procedure, and we could still be successful.
What is IVF surrogacy, doctor? We've got a number of people asking us to explain about IVF surrogacy.
Surrogacy is when the mother is not able to, it's renting a womb. So when the mother's eggs will be there and the father's sperms will be there, but then the baby will be developing in the surrogate. That's what is surrogacy means. When the patient is not able to bear the child because of she has got absent uterus, or she has got some severely problems like severely diabetic or hypertensive, or severe morbidity factors like she had a renal transplant, or she has cancer and she's undergoing chemotherapy or something like that. If it happens to the women, then the surrogate will carry the baby with the eggs of this woman, and then the surrogate will carry the baby and deliver the baby.
What is the success rate of IVF procedures in India, doctor?
It's around 45 to 50% max.
And can we select the baby's gender through IVF in India?
That's absolutely wrong thing to do, and it's totally banned. The sex selection is totally banned, and I don't think it's necessary, and I don't think we should be doing it. We only we look at the sex in case a few of the diseases which can affect the female child or the male child, then you can look at it for that purposes, but that also is really kept confidential. We never disclose any sex to anybody. No.
How is Apollo Cradle Chennai taking IVF to the next level, doctor? Are there any new technologies that the hospital has introduced?
Yes, there is a state-of-art IVF facility in Apollo Cradle, Shafi Mahmud Road, and it's a newly built unit. It has been there in main Apollo, which was shifted to Apollo Cradle. We have got excellent results. 3 of us do the IVF program here, myself, Dr. Kritika, and Dr. Kanimali. And all 3 are very well trained and very well qualified people. And we do get patients all over India and also from other countries like Bangladesh, Muscat, Oman we get, and people from Nigeria, and all those patients also come in. And we have a separate IVF unit, and we have a couple of fellows as well who work with us. We have IVF counselor who will counsel the IVF program as such. And basically we have a separate andrology lab and IVF unit, which is in the third floor. And the other than the ICSI procedures are done, assisted hatching, laser assisted hatching is there, and also pre-genetic diagnosis and pre-genetic screening is being done here.
Hello, doctor. I just want to know that is 7.4 endometrium good for an IVF treatment? Will it help attach the embryo? Please let me know, because many doctors have told me it is not good and I need to forget conceiving.
See, 7 to 8 is reasonably good. I mean, you prefer it to be 8, but then in more than, I mean, too much of endometrial thickness also is not so good. So 7.4 is absolutely fine to go ahead with the embryo implantation should happen.
We have another question. I have a condition called oligospermia. I have to go for IVF, ICSI, but due to low sperm count and quality, the doctor is not so hopeful for a successful outcome. I have asked the doctor to wait for a few months so that I can improve the semen quality. There's a huge variation between my semen analysis done in an IVF lab and that which is done in a pathology lab. What could be the reason, doctor?
It's very important that you do it in the IVF lab, because as soon as the semen is the preparation, how you collect it, basically starting off from the abstinence, how you collect the sperm, how you abstain from the relationship and then collect the sperm, and also how the processing is being done is very, very important. Actually, in a pathology lab, you would leave the sample there and it can be done after a few hours. Whereas in the IVF lab, it will be collected immediately and it will be checked immediately. So it's important that you take care, you do the semen analysis only in the IVF lab. That's number one. Number two is the oligospermia. Depending upon the count, if it is very low, it's severe oligospermia, then IVF ICSI is the option. And yes, the success is slightly lesser when you actually have very severe oligoasthenos teratospermia, we call it. It's called OATS, where the fertilization may not be that good and the quality of the sperm also may not be that good.
Is IVF treatment as a process painful?
No, not at all.
And does it require complete bed rest after every session of IVF?
Absolutely not. Once the IVF, you get pregnancy with the IVF program, then it's similar to patients who got spontaneously pregnant. So absolutely no indication to have bed rest after IVF treatment. That's number one. Number two is it's absolutely not painful procedure, but you need a lot of support from your family, from your husband, from your parents, and from your doctor, of course.
What will be the size of the uterus wall to get pregnant? My wife is 40 and we have tried 3 cycles of IVF, but every time she has had a miscarriage within the first 3 months. It did not succeed due to the uterus wall size, is what I was told. It was 6.2 to 6.3 mm. Is there any food that will help? What should we do? We are very saddened about it.
Healthy eating would help, but it doesn't really help in the implantation. Yes, the endometrial thickness is slightly on the lower side only. It's only 6.4. So I think improving the endometrial thickness would help, and also having a hysteroscopy to rule out any possibility of TB endometritis or subclinical endometritis, which is happening secondary to bacterial infection, has to be ruled out so that you have a better chance next time.
I have been taking Sustain 200 since November. When do I stop taking Sustain, and when can I check for pregnancy? My doctor has subscribed Sustain 200 on the 21st day of the period. Please suggest.
Normally, the progestogens are quite rampantly used for any indication for any pregnancy. You come with a spotting, you come with a little bleed in a spontaneous pregnancy, or you do an ovulation induction. We normally, it has been rampantly used, but then there is the progesterones have a role only in IVF program as such. There's no indication for an ovulation induction or for an IUI, in fact, or for a spontaneous pregnancy where they have a little bleed, an implantation bleed, progesterones will not help.
Can you let us know a little bit about endometriosis and adenomyosis, doctor, and how is it interrelated with IVF?
Yeah. See, endometriosis is when the lining of the uterus is deposited outside the uterus, and then whenever there's bleeding during the periods, it also bleeds from outside. So, because of this, there will be a lot of cysts which can develop, or endometriotic cysts which can develop, or it can be behind the uterus. There can be endometriosis as well, where the uterus gets attached to the bowel, and the relationship itself can be a problem. Having a intercourse itself can be a problem. It's very important that it is identified, the problem is identified by an ultrasound scan and treat it surgically, especially if it is not a grade 3 or grade 4 endometriosis. It can be treated surgically and they'll have very successful stories. Adenomyosis is again the lining of the uterus is deposited outside in the muscle layers of the uterus. But whenever there's a bleed from inside, it also bleeds from the muscle layers of the uterus. So that is adenomyosis. Adenomyotic uterus, they can form a single muscle masses like adenomyomata, we call it. That has to be removed surgically. So there is a place for surgery in fertility patients as well, and IVF is not the ultimate treatment. So surgical treatment, fertility enhancing surgeries we call it, and fertility which will help with the pregnancies.
Hello, doctor. I'm 38 years old. I had done family planning after my first child. I would like to conceive again. Will IVF help?
Yeah, of course, IVF would help, but then again, tubal recanalization also will help. If you had a tubal ligation done, then we just have to do a laparoscopy to find out how much of the tube is left out proximally and distally, and then we have to trim the ends and then recanalize it. The success with the recanalization is around 25%. With IVF, you may have a better success like 40% or 45% because already you had a child. But then again, the risk of or the small risk of tubal recanalization is there is a chance of ectopic pregnancy happening as well, which you have to keep in mind because the tubes are being recanalized again. But people who cannot afford IVF treatment, tubal canalization is the best modality of treatment. And as an Apollo group, we have done a lot of tubal recanalizations for tsunami hit patients during the tsunami time, and we had great success in those patients.
Hello, doctor. I'm diabetic since 2012. I'm suffering from impotency. What should I do? I'm 27 years old now. Will my wife be able to conceive naturally, or should I approach medical help?
Definitely, your wife will be able to conceive naturally. Your sugars have to be controlled, and you have to see a diabetologist, good diabetologist, and good sexual medicine doctor. So I'm sure the erectile dysfunction will subside once your sugars are under better control.
What are the myths associated with IVF today, doctor?
Yeah, basically they think, oh, are the babies going to be normal? As is to start off with, should I have to be on the bed rest? Absolutely not. You don't need bed rest. Is it painful? It's not. As I said, if you have good support system, that is not painful at all, and it can be taken very well. And mentally, you have to be really strong and prepared to go ahead with the IVF treatment. And the other thing is, okay, if my baby is born through IVF, will I have an abnormal child? Will my baby be different from others? Whether the developmental delay will happen? That's absolutely not. Okay, so these babies will have the same amount of risk what the spontaneous pregnancies will have, and there are several studies, several reviews which have been done all over from quite a number of years, and it suggests that it may be a slight increase in the risk, but then again, when we actually counsel the patients, the risk is it's almost the same as spontaneous pregnancies.
What is your message for our viewers today, doctor?
Yeah, to start off with, if you're planning for a baby, first of all, try to understand, husband and wife try to understand each other, and you have to start off with a good relationship. Doesn't mean mentally a physical relationship. I mean, mentally also you have to be compatible to each other, and then you plan a baby. So without fighting 24/7 and wanting to have a baby, that doesn't work. Okay, so you have to bring the baby to a good atmosphere and a stable relationship. You have to bring the baby. That's number one. Number two is, with the current lifestyle, which is very difficult for everybody, you have to make sure that you drink moderately, you smoke moderately, and also if you can, if you plan for the baby, before you plan for the baby, stop smoking and drinking, women and men, and also change your lifestyle as well. Exercise regularly, eat healthy, decrease the fatty foods and oily foods and junk food, and then you plan for the baby. And the other important thing, as I said before, get vaccinations done, get the routine blood investigations done, and then go ahead with the pregnancy. And the other important thing is, if you're trying for 1 year and it did not really happen, and if you're approaching the age of 35, especially the women, it's better to see a doctor, seek the help. Okay, and you have to make sure that you go to the right fertility specialist or general gynecologist to start off with, and if necessary, go to the fertility specialist. And don't succumb to saying that, do IVF immediately. So there are other methods, like if your tubes are okay, your husband's sperm is mildly abnormal, then you can still go ahead with ovulation induction with a timed relationship, or an IUI if the sperm counts are lesser. And then if it is not successful, then you can go ahead with the IVF treatment, because everything has got its own pros and cons. Yeah, that's about it, actually.
Thank you very much for a wonderfully informative session, Doctor.
Thank you, viewers.
For appointments with Dr. Sumana, please reach out to 044 2829 6693. I repeat, 044 2829 6693. Thank you, Doctor. Thank you, viewers.